Hello, and welcome to Elevate, a GE Healthcare education webinar series. Thank you for joining today's webcast titled Applying Alveolar Recruitment Maneuvers in the Operating Room, Physiological Concepts and Practical Recommendations, which will be delivered in just a moment by Dr. Christopher Young. My name is Lisa Nolan, and I am the Global Clinical Insights and Education Leader for the Anesthesia and Respiratory Care Division at GE Healthcare. I'll be facilitating today's webinar. Dr. Young is a professor of anesthesiology in the Division of Critical Care Medicine at Duke University Medical Center. He received his undergraduate degree from the College of the Holy Cross and his medical degree from the New York Medical College. He has served in the Department of Anesthesiology at Duke as Division Chief and Fellowship Director in Critical Care Medicine. As a practicing anesthesiologist and intensivist, the provision of lung protective ventilation is among his clinical and research interests. He will discuss the current evidence supporting the use of alveolar recruitment as a crucial component of LPV in the surgical patient. Now, I'll pass it over to Dr. Christopher Young.
Thank you, Lisa, and thank you to all the people at GE Healthcare who have supported this webinar and who continue to support education of practitioners with the goal of reducing postoperative pulmonary complications. I would also like to thank all of the participants today, and I look forward to your comments and questions at the conclusion of this talk. Respiratory failure after general anesthesia is one of the most critical factors associated with poor patient outcomes. Postoperative pulmonary complications, or PPCs, are more common following elective surgery than cardiac ones. They are second only to skin and surgical site infections in incidence and are the single most expensive driver of additional medical expenditures and a leading cause of death in the postoperative period. Up to 20% of patients who develop PPCs will die as a result of them. It has recently been found that ventilator driving pressure is a significant predictor of postoperative morbidity and mortality. Here I illustrate driving pressure through one mechanical breath. You can see positive pressure is being delivered over a PEEP of 5, and we get a peak pressure of 20 centimeters of water. However, after a bit of an inspiratory pause, we see that the pressure drops down to a second level called the plateau pressure, and the difference between this plateau pressure and the PEEP is designated the driving pressure. In this example, we see a plateau pressure of 16, a PEEP of 5, giving a driving pressure of 11. A recent review of postoperative pulmonary complications in surgical patients found that increasing driving pressure was associated with increasing vulnerability to pneumonia, pulmonary edema, reintubation, and ARDS. The authors also noted that peak airway pressure, plateau pressure, and tidal volume did not have the same strength of association with those postoperative pulmonary complications. During positive pressure ventilation, driving pressure is related to tidal volume through compliance. A highly compliant lung will have a smaller change in pressure for a given tidal volume than a less compliant lung. Forcing air into the lungs during mechanical ventilation, particularly if their compliance is poor, can lead to increased stress and strain forces on the lung, which is known to result in lung injury and increased risk of PPCs. Let's look at how anesthesia affects lung compliance even in healthy patients, and how reduced compliance contributes to lung injury via increased driving pressure. We can then look at ways to improve compliance and perhaps reduce PPCs. In this depiction of lung spirometry, we can see normal tidal breathing of about 7 mL per kilogram body weight. It occurs on top of a functional residual capacity, or FRC. You will recall from pulmonary physiology that FRC, a capacity, is composed of two volumes: expiratory reserve volume, ERV, and residual volume, RV. Normal FRC is about 30 mL per kilogram. In the normal spontaneously breathing situation depicted here, lung stress and strain are minimal. I have mentioned the interrelated terms of stress and strain a few times. These are materials engineering concepts that help in understanding the pathophysiology of positive pressure ventilation-induced lung injury. Stress is simply the force applied to a material, in this case alveoli, divided by the area of the material. If the same force is applied to a smaller amount of material, the stress is increased. So if we apply the same tidal volume or driving pressure to a partially atelectatic lung, the stress on those functioning non-atelectatic alveoli is increased. Strain is also a helpful concept. It relates to the change in dimension of an object compared to its original dimension. For example, it can be used to determine the stress on a spring from its original state to a stretched one. In the case of the lungs, volumetric strain is the change in lung volume, or tidal volume, relative to its original volume or FRC. So here again we see the normal tidal volume and FRC in an upright, spontaneously breathing 70-kilo person. Let's look at what happens to these lung volumes when we provide anesthesia. This is the pre-anesthetic state with a tidal volume of about 500 mLs and a functional residual capacity of about 3 liters. When we induce anesthesia, several things happen. First of all, just changing from the upright to supine position while awake reduces functional residual capacity by about 800 mLs to a liter. Loss of muscle tone during induction of anesthesia further reduces resting lung volume an additional 0.4 to 0.5 liters. And this is true of both inhalational and IV anesthetics. Note that when we're providing positive pressure ventilation after anesthesia induction, we usually refer to end expiratory lung volume, or EELV, rather than FRC, but the terms are often used interchangeably. So here we see a spontaneous respiration occurring with a tidal volume of about 500, FRC of 3 liters, as we talked about, producing a volumetric strain of about 16%. Again, this is the normal, upright, spontaneously breathing individual. Once an individual moves from the upright to the supine position, we see an immediate reduction in FRC, such that the volumetric strain for the same tidal volume is now at 23%. Following anesthesia induction, there's further reduction in FRC, so that we now have a volumetric strain of about 33%. A significant increase from the baseline state. In this slide, we see a lung compliance curve with the I indicating the inspiratory limb and the E indicating the expiratory limb of a single breath. You can see the sigmoid shape of the curve with the midsections of both curves being much steeper, indicating a higher level of compliance compared with either end where the curve flattens out and compliance is decreased. You also see the effect of hysteresis, so that there's an offset between the inspiratory and expiratory curves, such that it takes a higher pressure for a given volume to inflate a lung than it takes to exhale and deflate that lung. Loss of lung volume that occurs during induction of anesthesia can place the patient on the flatter portion of the compliance curve. Therefore, for a given tidal volume, driving pressure remains fairly small during normal compliance and increases as compliance decreases. This decrease in compliance and resultant increase in driving pressure can lead to increased strain of the lung. Again, strain is given as the ratio of tidal volume to FRC. As FRC decreases, strain must therefore increase, and as tidal volume decreases, we can reduce the strain on the lung. This is the basis of the recommendation for low tidal volume ventilation. However, keep in mind that tidal volume alone does not determine risk of lung injury because it does not take into account what the FRC is prior to the initiation of that breath. And so a low tidal volume being delivered into an extremely low FRC may still be associated with increased strain and risk of lung injury. Therefore, controlling tidal volume alone is not enough to protect against lung injury. It's important to focus on what the FRC, or end expiratory lung volume, is in an individual to really find the degree of strain that's present in that system. While the application of stress and strain calculations to intraoperative pulmonary mechanics is a relatively recent addition, it was evident from the early days of mechanical ventilation that impaired oxygenation occurred frequently and progressively during general anesthesia. In 1963, Ben Dixon and colleagues published this paper in the New England Journal of Medicine. In this paper, they introduced the concepts of atelectasis and progressive hypoxemia that occurs during prolonged general anesthesia. These authors then went on to propose a series of periodic passive inflations similar to the sighing process that occurs normally in patients who are breathing spontaneously. These authors suggested the use of a 20-centimeter sigh breath, or what we would now call recruitment maneuver, for 10 seconds, followed by a 30-centimeter breath for 15 seconds, and finally a 40-centimeter of water breath for 15 seconds. Essentially, they are recruiting collapsed alveoli with these interventions. Large tidal volumes, 10 to 15 mLs per kilo, were used to improve the atelectasis throughout the 60s, 70s, 80s, and 90s following publication of this article. It wasn't until this publication in 2000 in the New England Journal of Medicine that looked at lower tidal volumes in ARDS patients that we began to think that maybe those large tidal volumes were not appropriate for use in the operating room. In this study, they compared traditional mechanical ventilation in ARDS patients of 12 mLs per kilogram, targeting a plateau pressure of 45 to 50 centimeters of water, versus the intervention group, or low tidal volume group, which received tidal volumes of 6 mLs per kilogram and a targeted plateau pressure of 25 to 30 centimeters of water. Quite interestingly, the mortality rate for the low tidal volume group was significantly lower than the high tidal volume group, about 40% versus 30%. Based on this study, new recommendations were put in place for all patients with ARDS to receive low tidal volume ventilation. In the operating room, those recommendations took a little longer to proceed. When we think about what was going on with these patients, they were being exposed to lung injury through the process of atelectasis. You may recall that atelectasis can injure the lungs in a number of different ways. Barotrauma and volutrauma are both closely related concepts which refer to the overinflation of alveoli. If you think back to the compliance curve and the sigmoid shape of it, that upper flat portion of the curve where compliance is very poor correlates with areas of overinflation and overdistension of alveoli, and that is where barotrauma and volutrauma can occur. On the low end of those sigmoid curves, again where it flattens out at the low volumes, the issue can become atelectrauma, in which alveoli are cyclically opened and closed over time, increasing the risk of injury to those alveoli. Taken all together, barotrauma, volutrauma, and atelectrauma can combine to produce an inflammatory mediated trauma to the lungs called biotrauma. Taken together, these are the mechanisms by which atelectasis produces postoperative pulmonary complications, lung injury, and postoperative respiratory complications. In addition, there is heterogeneity of lung expansion, meaning that some areas that are expanding well are adjacent to areas that are atelectatic. And that interface area between those two zones are subject to amplified stress. It's been estimated that the stress occurring at these transition zones can be 3 or 4 times the stress just from the shear forces and strain forces that are occurring on that lung. In 2013, 50 years after Ben Dixon's publication, Foutier et al. Published this article in the New England Journal of Medicine looking at a trial of intraoperative low tidal volume ventilation during abdominal surgery. In this study, the high tidal volume approach was tested against a low tidal volume based approach that used periodic recruitment maneuvers to maintain alveolar patency. The improved trial randomized 400 adult patients undergoing major abdominal surgery into either a low tidal volume group or a standard 10 to 12 ml per kilogram tidal volume group, and looked at a composite outcome of major pulmonary and extrapulmonary complications. The low tidal volume group received 6 to 8 mLs per kilogram predicted body weight tidal volumes with 6 to 8 centimeters water PEEP, and recruitment maneuvers performed every 30 minutes of 30 centimeters water for 30 seconds. The control group received tidal volumes of 10 to 12 mLs per kilogram predicted body weight with no PEEP and no recruitment maneuvers. The composite outcome of major pulmonary and extrapulmonary complications occurred in 10.5% of the low tidal volume group and 27.5% of the high tidal volume group, a significant reduction in harm with the use of low tidal volumes, PEEP, and recruitment maneuvers. There was also a 2.5-day reduction in hospital length of stay. These results demonstrated for the first time that patients without ARDS could likewise benefit from low tidal volume ventilation with moderate amounts of PEEP and recruitment maneuvers, an approach termed open lung ventilation. A number of studies investigated the impact of recruitment maneuvers and open lung ventilation from Ben Dixon in 1963 all the way through studies published through 2009. This paper, published in 2019, sought to review the growing body of evidence of protective lung ventilation in the operating room and provide expert-based recommendations. I was fortunate to serve as the moderator of a discussion on lung protective ventilation among this international panel of experts. Using a standardized grade approach to literature review and establishing consensus using the Delphi method, the panel produced a number of specific recommendations for lung protection in the operating room. The expert panel found evidence supporting the use of low tidal volumes and moderate levels of PEEP in patients undergoing anesthesia. However, I want to focus more on the recommendations of the group concerning alveolar recruitment maneuvers. The expert panel reviewed 33 studies of recruitment maneuvers that met inclusion criteria and concluded that ARMs should be performed after a disconnection from the circuit and whenever the patient's saturation is consistently less than 94%. One should evaluate change in respiratory system compliance and driving pressure after a recruitment maneuver and repeat the recruitment maneuver with a longer inspiratory hold or higher pressure if recruitment is assessed as ineffective. And finally, recruitment maneuvers should be performed using the lowest effective peak inspiratory pressure and shortest effective time or fewest number of breaths. So the weight of the scientific evidence and subsequent recommendations by the expert panel supports the use of recruitment maneuvers and PEEP to maintain open lung condition in patients undergoing anesthesia and surgery. It should be remembered that PEEP alone can cause overdistension of open alveoli and may lead to minimal alveolar recruitment, while recruitment maneuvers alone will increase the number of alveoli that are in the open state, but de-recruitment can occur quickly afterwards. And so recruitment maneuvers and PEEP must be used in combination to recruit alveoli, maintain them in the open state, and prevent further atelectasis. Also, keep in mind that the intermediate and high-risk group of patients undergoing surgery and who would benefit most from the use of recruitment maneuvers and PEEP include those with increased intra-abdominal pressure, those undergoing laparoscopic intra-abdominal surgery or surgery in the Trendelenburg position, as well as patients with obesity and those undergoing cardiac surgery. Let's look more closely at some of these high-risk situations. Patients undergoing laparoscopic surgery have increased risk of postoperative pulmonary complications due to the insufflation of the abdomen and subsequent cephalad displacement of the diaphragm. In this study by Pereira and others, the investigators used electrical impedance tomography, or EIT, as a way to measure the amount of atelectasis present in patients during anesthesia and surgery. Electrical impedance tomography is a technique whereby small electrical currents are used to image the chest, much like a CT scan does, but without the use of ionizing radiation. These authors chose 40 non-obese subjects to investigate. Half the subjects underwent open surgery and half underwent laparoscopic. You can see that after randomization, the selected PEEP was significantly different between the two groups. The PEEP 4 group maintained their PEEP right around that level of 4 centimeters of water throughout the procedure, while the EIT-guided PEEP group received an average PEEP level of 13.2 centimeters of water for laparoscopic surgery. For open surgery, likewise, there was a PEEP of 4 in the control group, and the EIT-guided group received a PEEP of about 10 centimeters of water, slightly less than what the laparoscopic surgery group received, as you would expect, because there was no insufflation of the abdomen occurring during open surgery. Here is one image from that paper depicting the differences in atelectasis between the group whose PEEP was selected based on electrical impedance tomography on the left and the control group of PEEP of 4 on the right. You can see in these tomograms with the blue reflecting atelectasis and the gray reflecting inflated alveoli within the thorax, that the PEEP EIT group had about a 3.5% collapse with just very minor amounts of atelectasis occurring in the ventral regions of the lung. As opposed to the PEEP 4 group, where there is a significant amount of collapse, here 49% as measured during the study during PEEP of 4 ventilation. In addition to the dependent lung collapse depicted in the previous slide, the authors also showed significant differences in driving pressure in the laparoscopic surgery arm of the study. The light gray curve with the open circles is the PEEP 4 group, and the dark curve on the bottom with the closed circles is the group that received PEEP titrated to the electrical impedance tomography. You can see that driving pressure in both groups was very similar at baseline, about 10 centimeters of water or so, and that it was reduced significantly after introduction of PEEP. However, once surgery began and insufflation occurred, we can see that the driving pressure in the PEEP 4 arm is significantly increased up into the danger range of greater than 14 or 15 centimeters of water, while the increase in driving pressure in the EIT titrated PEEP group was somewhat mitigated and only reached about 8 or 9 centimeters water driving pressure. Obesity, as mentioned earlier, increases the risk of PPCs. Worldwide, the incidence of obesity is seen to be increasing, producing a significant burden for anesthesiologists providing anesthesia for patients presenting with obesity. There are significant implications, including increased likelihood of difficult airway and more rapid desaturation following apnea. The presence of obesity independently increases the chances of postoperative respiratory complications. In this study, we see that resting lung volume decreases further with increasing BMI. So FRC is measured on the vertical axis and BMI is given on the horizontal axis. And we can see that as the BMI increases, FRC is gradually decreased, explaining the rapid desaturation that occurs during intubation, and also helping to explain how the lung is collapsed due to loss of FRC, and tidal volumes therefore produce more strain on the lung of obese patients, and the use of low tidal volume ventilation is important therefore in managing patients with obesity. In that same study by Pereira and others, we see the influence that BMI has on the need for PEEP to minimize atelectasis as measured by electrical impedance tomography. Here we see 40 patients with BMIs ranging from the mid-20s to the high 30s, and the amount of PEEP that was titrated in those individuals. There's a fairly linear relationship between BMI and PEEP levels, such that patients with lower BMIs in the 22 range or so required about 9 centimeters water PEEP, and that progressively increased so that the highest BMI patients required about 14 centimeters water PEEP to maintain the open lung condition. In reviewing studies like Pereira's looking at the influence of BMI on PEEP levels, we have put together at Duke a recommended minimum PEEP to prevent airway closure based on individual BMI. And that ranges from 6 to 7 centimeters water for normal less than 25 BMI to 15 centimeters or more of PEEP in patients with BMIs greater than 50. It has to be remembered that these recommended PEEP levels are based on published studies, but applied PEEP needs to be individualized and will change during a case based on ongoing compliance changes. In this study, published in 2020 Anesthesiology by Tharp and others, the investigators looked to see how both body habitus, obesity, and dynamic surgical conditions, such as laparoscopic insufflation of the abdomen and steep Trendelenburg position, impacted pulmonary mechanics during robot-assisted laparoscopic surgery. The authors placed esophageal manometers in all patients presenting for surgery in this study and used esophageal pressure measurement as a surrogate for pleural pressure. When pleural pressure is known and airway pressure is known, the difference between the two estimates transpulmonary pressure and can be used to determine the optimal PEEP. As you can see, there was a correlation at baseline between BMI and optimal PEEP levels as measured by transesophageal pressure. The lowest BMI patients required a PEEP of about 8 centimeters of water, whereas patients with BMIs greater than 40 required PEEPs approaching 20 centimeter water level. You can see in addition that relationship holds during both pneumoperitoneum and Trendelenburg positioning. It should be noted that in the previous studies, the application of PEEP was always preceded by a recruitment maneuver, and that increasing levels of PEEP were often associated with increasing levels of inspiratory pressure to open the lungs and maintain the lungs in their open state. What about during cardiac surgery? In this study, published by Lemay et al. In 2017, they present the results of a single-center randomized clinical trial of postoperative ventilation comparing a moderate recruitment and PEEP strategy with a strategy combining higher levels of PEEP and recruitment maneuvers in hypoxic patients after cardiac surgery. Postoperative ventilation with intensive recruitment was 45 centimeters water recruitment maneuver and a PEEP of 13 in 157 patients, and this was compared to a moderate recruitment maneuver of 20 centimeters of water and PEEP of 8 in 163 patients. The authors found that the intensive recruitment PEEP group had shorter length of intensive care unit stay, 3.8 versus 4.8 days, and overall hospital length of stay, 10.9 versus 12.4 days. In addition, the intensive ventilation group was found to have reduced driving pressures. One concern that is sometimes raised in the operating room when I'm performing recruitment maneuvers and PEEP trials is, does this increased intrathoracic pressure impair left ventricular or right ventricular output? The answer, I believe, is no. The improved VQ matching that results from opening collapsed alveoli reverses hypoxic pulmonary vasoconstriction and improves both RV and LV function. I think that's brought out by this study by Longo et al., who looked at lung recruitment following cardiopulmonary bypass in the operating room. The authors found that the RV function parameters were mildly decreased in 95% of patients without significant differences between groups. However, after surgery, cardiac index decreased further in the control group, but actually increased in the recruitment maneuver and PEEP group. RV function only improved in the recruitment maneuver group, and atelectasis was present in 100% of the patients in the control group, but only 10% of those who received recruitment maneuvers. The most common question I get in regards to recruitment maneuvers and PEEP in the operating room is it safe? Well, let's look at the literature, because I believe it is. Often those who are concerned about the safety of lung recruitment and titrated PEEP bring up this trial, the ART trial, published in JAMA. In this trial, they found a 6% increase in absolute mortality in a group of ARDS patients receiving recruitment maneuvers, and they also showed increased rates of pneumothorax and barotrauma compared to the control group. However, I don't think that this study should dissuade us from using PEEP in the operating room for a number of reasons. First off, we're dealing with a different pathophysiology during general anesthesia than is seen during ARDS. In anesthesia, we see quite a bit of atelectasis as previously described, whereas in ARDS, atelectasis is a component, but it may not be the main component that's going on. In addition, the inflammation and edema formation that is the hallmark of ARDS lungs is not seen during standard general anesthesia cases with healthy lungs. Likewise, the management differs. Although both ARDS patients and general anesthesia patients benefit from low tidal volume, the recruitment maneuvers are important in general anesthesia as they reverse the pathophysiology of atelectasis due to compression and absorption of high FiO2 gases, whereas in ARDS, recruitment maneuvers may or may not be indicated depending on whether it is primarily atelectasis or primarily inflammation and edema that's at play in that individual patient. The ART trial looked at patients with persistent ARDS, and I would suggest that's not the same as general anesthesia-related atelectasis. In addition, their recruitment maneuver was 60 centimeters of water held for 2 minutes times 2, significantly higher pressures for a significantly longer period of time than we use in the operating room or that are required to reverse atelectasis associated with general anesthesia. In fact, this protocol was so extreme that there was a change in protocol after the initial patients showed significantly high mortality and barotrauma following the 60 centimeter water recruitment maneuver. There's also some questionable statistical significance of the study, as well as multiple positive trials of recruitment maneuvers in ARDS, such as the LOVES trial and the OLA network trial. Finally, the recruitment maneuvers were the same for all patients, regardless of BMI, and not individualized to the individual patient's BMI, as was suggested to be done in the operating room in the previous slides. The previously referenced consensus paper found that alveolar recruitment maneuvers are in fact safe in the operating room. In 26 of the 33 studies that were reviewed, no adverse effects occurred. In 6 of the 33, patients required the transient use of vasopressors or fluid to maintain blood pressure and subsequently went on to have recruitment maneuvers with no adverse effect. And finally, one paper of the 33 described transient oxyhemoglobin desaturation, which resolved immediately upon cessation of the recruitment maneuver. So continuous monitoring of both hemodynamics and oxygen saturation is required during a recruitment maneuver, and they should be performed at the lowest level for the shortest period of time. It's been found in the literature that a 40 centimeter water pressure recruitment maneuver held for 7 seconds is adequate to recruit most of the collapsed alveolus during a general anesthetic. And of course, alveolar recruitment maneuvers should be avoided when contraindicated. What about other high-risk patients, like the elderly or those with cardiac comorbidities? Well, Weingarten showed in 2010 that elderly patients undergoing major abdominal surgery tolerated recruitment maneuvers and a PEEP of 12 quite well without significant hemodynamic instability. Rees-Miranda in 2005 showed that cardiac patients receiving recruitment maneuvers with a PEEP of 14 centimeters of water demonstrated decreased dynamic RV impedance, while ventilation without recruitment maneuvers and PEEP of 5 increased RV outflow impedance. This is consistent with the previous study we looked at in postoperative cardiac surgical patients in whom high levels of recruitment maneuvers and PEEP were associated with improvements in RV and LV function. Finally, Tussman in 2010 showed that patients with poor LV function and ejection fractions less than 30% had reduced pulmonary vascular resistance after recruitment maneuvers and PEEP of 10 centimeters water, with continued stability in their hemodynamics throughout the course of the operation and significant reductions in pulmonary vascular resistance. So recruitment maneuvers restore and preserve resting lung volume. They restore FRC through alveolar recruitment, and they preserve FRC with adequate expiratory pressure, or PEEP. It is important to remember that recruitment is both pressure dependent and time dependent. The amount of pressure required to restore lung volume is dependent on the degree of alveolar collapse and patient factors such as BMI and lung and chest wall compliance, as well as surgical factors such as positioning and pneumoperitoneum. The amount of pressure that's required, of course, varies with BMI. The minimum recruitment pressure for all patients is about 40 centimeters of water, and in higher BMI individuals, it may be as high as 60 centimeters of water. Recruitment is also time dependent. Certain alveoli have a time constant that requires a longer exposure to pressure before they will reopen. As you can see in this slide, at about 7 to 10 seconds, most of the alveoli are recruited, and recruitment maneuvers going beyond 10 seconds or so are really not required and may just further worsen hemodynamics rather than help with opening more alveoli. So the recommendation is to keep recruitment maneuvers at the lowest pressure possible for the shortest period of time. And the recommendation is to start at 40 centimeters of water for about 7 to 10 seconds. A number of techniques have been described to produce a recruitment maneuver. On the top left panel on this slide, you see the bag squeezing technique. You can see that over time, as ventilation is being delivered, a large breath is delivered, here 30 centimeters water pressure for a certain period of time by squeezing the bag on the anesthesia machine. However, you can see that at the termination of the bag squeezing, pressure drops back down to zero before incrementally increasing back to the set PEEP level. And this is a problem because it results in de-recruitment of those alveoli after the recruitment maneuver. Therefore, bag squeezing technique is not recommended. In fact, one retrospective analysis of data suggested that there was an increased mortality signal in patients who received recruitment maneuvers through a bag squeezing technique. And so the expert panel that reviewed the studies suggested that any type of recruitment maneuver ought to be done through the anesthesia machine and not through squeezing the bag and then switching back over to the anesthesia ventilator. In panel B, we see a CPAP type of recruitment maneuver. It is similar to a bag squeezing technique in that a pressure is chosen, in this case 30 centimeters of water, and held for a period of time, usually 7 to 10 seconds is sufficient, before initiating the ventilation on the right side of the CPAP with increased PEEP. This technique is very similar to the bag squeezing, but it is done through the ventilator. In addition to these vital capacity type of maneuvers, the bottom two panels show two different types of cycling maneuvers. In panel C, we see that the tidal volume pressure is maintained fairly constant while PEEP is incrementally increased. And in panel D, we see that PEEP is maintained at a constant level of about 8 centimeters water, and there are stepwise increases in tidal volume. Either one of these techniques is adequate and should result in sufficient recruitment following completion of the recruitment maneuver. Again, one should be using the lowest recruitment pressure for the shortest period of time that is consistent with good recruitment of alveoli. And these guidelines suggest that a pressure between 40 and 60 centimeters of water is sufficient depending upon patient BMI. In the next few slides, I'd like to show you an example of a recruitment maneuver. Keep in mind that the settings used in this recruitment maneuver are specific to the patient being treated, and that the settings can be individualized based on patient needs. In addition, if you don't have the ability to have a pre-programmed recruitment maneuver on your ventilator, the same steps can be repeated manually. This particular anesthesia machine has a programmable cycling recruitment maneuver feature. This recruitment maneuver is set at a respiratory rate of 15 and will deliver 3 breaths in the first step at an inspiratory pressure of 10 and a PEEP of 8. During this cycling maneuver, the ventilator will continue to deliver increasing levels of PEEP and inspiratory pressure through the series of 6 steps, providing 3 breaths at each step and gradually increasing delivered pressures with each step, raising pressure gradually as opposed to a vital capacity maneuver, until the final airway pressure is achieved, in this case 40 centimeters of water. This is an example of a patient who received a recruitment maneuver and increased PEEP in response to a low respiratory system compliance that was noted intraoperatively. You can see on the left-hand side, the patient has a measured respiratory system compliance of 11 mLs per centimeter of water. At that point in time, he was receiving a PEEP of 5 with a driving pressure of 14 centimeters of water, which resulted in a tidal volume delivered of 150 mLs. This was clearly not a good situation for the patient, as he was experiencing troubles with both CO2 removal and oxygenation. As a result, a stepwise recruitment maneuver was performed and a final PEEP level determined to be 15 centimeters of water, which was consistent with an improved compliance of 43 mLs per centimeters of water. As you can see, the driving pressure was maintained at 14 centimeters water. However, this is now associated with a much improved tidal volume of 600 mLs. As a result, oxygenation and CO2 removal were improved, and the patient did well subsequent to this recruitment maneuver and PEEP trial. I would like to close with some thoughts on how to implement LPV in your own practices. In addition to providing educational resources to your colleagues, such as this webinar, there are steps you can take that can help transition to LPV in daily practice. Making ideal body weight readily visible in the anesthesia record is a useful step in setting appropriate tidal volumes. Resetting default settings on the ventilator to a lower initial tidal volume and higher initial PEEP can be helpful as well. Displaying the respiratory system compliance continuously on monitors is a helpful reminder to keep an eye on this important factor. Emphasizing driving pressure over things like peak or plateau airway pressures should also help in improving long-term outcomes in patients undergoing anesthesia and surgery at your institution. Finally, you can track adherence with the recommended tidal volume, PEEP, and recruitment maneuvers and provide feedback either individually or as a group. By using the steps I just described at Duke, we were able to improve adherence to lung protective ventilation protocols as seen in this slide. While the average median tidal volume decreased somewhat, the percentage of tidal volumes that were being delivered between 6 and 8 mils per kilogram increased significantly from 53% to 71%, and that was associated with an average median driving pressure drop from just over 15 to below 13. You can also see that our average median FiO2 decreased during that period of time, and the average median PEEP increased from 4.83 to 7.1. I hope I have demonstrated the value of lung protective ventilation, recruitment maneuvers, and PEEP in ventilatory management in the operating room, and given you some of the tools needed to implement lung protective ventilation in your practice. Thank you very much.